That now takes us on to our next speaker, who is Sebastian, who is the head of pediatric cardiology services at University Children's Hospital in Poland. Sebastian trained at the Polish Mothers Memorial Hospital and actually came across to the Evelina to do his intervention fellowship and is well known amongst the trainees here. I bumped into him in Denver, where we were both on fellowship, and it's there where he really got me and opened my eyes to what the cath lab can actually achieve and some of the more advanced angiographic techniques. To the extent that we had one of the vendors who came to teach us about some of the Philips equipment, and within 5 minutes, Sebastian was actually teaching the vendor what to do. So he has a huge interest in advanced imaging. He's published numerous publications, and it's an honor to have him joining us here today. And I hope this is the start of our friendship and collaboration. Over to you, Sebastian.
Riz, thank you very much for that kind of introduction, and thank you for invitation and for having me. I just want to make comment to the previous comment that if there's any junior people listening to that and are interested in high numbers, I welcome them to Krakow, to Poland. We do lots of hybrids as well, so send me an email. And if you're interested in 3D imaging, I'm also happy to share my thoughts. I was asked to talk about advanced angiography, and as you will be able to see on my slides, in some cases, advanced angiography for me is no angiography at all. But before we get there, I have no disclosures except that I'm actually a believer in 3D imaging in a cath lab, so I'm totally biased and I'm not objective, and you might buy into these ideas or not. When you think of advanced imaging in a cath lab, so there are many ways to visualize our target structures, and obviously three-dimensional imaging started in cath lab with 3D array, then there was echo fluorofusion, and currently we also have CT MRI fusion with fluoroscopy. There we've heard for several years about holography, but also 3D printing is a way of using imaging and to guide our interventions or to plan our interventions. I will focus in my presentation on two of these techniques, that is three-dimensional rotational angiography and fusion of CT and MRI. Before we move on to the next slides, just think for a moment whether you can come up with a single intervention that is only doable with 3D imaging. I guess it's going to be hard because most, if not all, of the interventions that we are conducting, they have been invented when there was just 2D imaging, and people learn to use 2D imaging and to be accurate and to do safe interventions. However, time has passed and world is moving on, and there are new possibilities now. But it takes, first of all, this step forward. You need to buy into the idea, and well, nice images, pretty pictures are helpful in convincing some of us. So this is the typical way one could treat coarctation or aortic atresia here with angiography step by step in 2 planes. But back in 2009, I joined team in Poland, in Łódź, and we had a similar situation. Our cath lab was rebuilt and we had a new imaging system installed. Unfortunately, at that time, it was single plane, but we were told that it's got that new thing that will make a biplane cath labs go away. So that was actually three-dimensional rotational angiography. And as you can see, we had a team of people with mixed experience, and it wasn't easy for some of them to buy into that idea. But along the way, most of us were convinced, and we worked as a team, not only as a team of interventional cardiologists, but you also need to have imagers, and you need to also cooperate with radiologists to have nice 3D data sets. Well, so we started with rotational angiography. Here you have example of contrast injection that is non-diluted, no rapid pacing, and you can see that we have multiple images in long axis of patient. And then we move to 3D reconstruction. In this case, there was not much to do, not much cutting or editing, but you can nicely see in many planes, actually an unlimited number of planes, you can see the target lesion and nearby branches. Then you can have that image overlaid, and actually it happens automatically, and you can guide your intervention. And this image actually shows also benefits, but the limitations. You know, that 3D array was taken with pig-type catheter, and now we have stiff wire, we have balloon stent, and we have long sheath. So we're definitely changing anatomy. So, and you can see on that image that the wire, the ascending aorta is definitely shifted, you know. But we learned actually to be more critical and to accept some misalignment. And in some cases, actually, we don't need to adjust that, and we just have to push our devices to one side or another, or sometimes change wire, for example, and we don't need a very stiff one. And here we can assess the outcome in rotational angiography in multiple views available with regular angiography, but the 3D reconstruction, again, gives us unlimited views. So in the early years of using 3D array, we thought that a single ventricle patient population was ideal for that technique because of slow blood flow and pulmonary arteries were the example, or Fontan conduit. But and I believe you have seen those interventions on some of the international meetings. But I want to focus here on one of the examples of the use of 3D array. And back in 2015, we did a live case for 3D array meeting in Utrecht in Netherlands, and that was actually PDA stenting in hypoplastic left heart syndrome. What I wanted to show you here, actually, that obviously without rapid pacing, and at that time with undiluted contrast, we were able to have nice images from rotational angiography, where we can actually already see here the origin of pulmonary arteries and beginning and end of the duct and the retrograde aortic arch. In this case, segmentation wasn't that easy. So you can see that there's a lot more noise. And at that time, we didn't have any tools to mark our target zone for the stent. So we thought of cutting here the distal end where we want to have the stent in. And finally, we have this 3D reconstruction. So we overlay it. Actually, the system does it automatically. And we have overlay on fluoroscopy. And you can actually see that the catheter there is well contained in that 3D reconstruction. And we have those structures required for accurate stent positioning. But when we introduced a slightly stiffer wire and delivery system, you can see that the wire in the descending aorta and in the pulmonary trunk is probably outside the 3D reconstruction. But the stent, as you will see here in that most important area, it is still contained within that 3D reconstruction. So this is how we implanted stent with no additional contrast injection, and then we did 3D RA to assess the outcome, where we have 2D images and 3D images, and those 3D images actually, let me skip to the next slide now, because the 3D images here show us a relationship of that stented duct to the nearby branches or the retrograde aortic arch. So we learned that with three-dimensional rotational angiography, we can obtain more knowledge and understanding about anatomy. We can actually, with single injection, we can know everything we want to know about, for instance, pulmonary arteries, and then we can select proper views, and we're not limited by just 2D angiography and some angulations. We can take measurements, and we can obviously look into surrounding structures, because a 3D array is a 3D data set, just like with CT images. But there were some limitations. It took time to learn that technique to set up the spin, because you have to go from RAO to LAO, so the test spin. You have to communicate with an anesthesiologist so that you don't dislodge air intubation tube and the pipes there. Well, you need to inject contrast, obviously, but along the way we learned that we can dilute contrast. Radiation was the issue initially, but with some specific setups and with discussions with vendor, we were able to limit that. There is this discussion that with 2D imaging we have dynamic images, whereas with 3D reconstruction the images are static. This is relevant for some structures, irrelevant for others, and I'll show a few examples later on. But the main thing is that you have to do the post-processing during the case. So the patient is on the table, the team is waiting for measurements, for 3D reconstruction, and you have to do the clicking during the case. So later, I think it was 2015 when we were provided with new software and we were able to overlay CT and MRIs. And this is example of aortic coarctation. This time, patient came to the lab with CT image, and you can see segmentation of that CT image. This is slightly different than 3D array because here you highlight what you're interested in. You don't have to cut it out. So you're building that model, and you can do it before the case starts. So you learn the anatomy, you take the measurements, you select how you want that 3D model to be projected, and you can also put some marking rings and marking points. And then you bring the patient to the lab and you have to do the registration. So you have to find internal markers, and we initially used bony structures to align that CT derived 3D model with live fluoroscopy. So we do that in two planes, and this is similar to setting up isocenter. So in AP and lateral and stored fluoroscopy, and then we can align the 3D volume with the overlay with fluoroscopy. But during the case, we also confirm whether that alignment is accurate, and the position of the wire in the arch, for example, gives us that information, or if the catheter crosses through the narrowest part of that coarctation. And then we also know that we have accurate alignment, and here we do the predilation of that lesion, and on the right side you can see a stenting of that lesion, and you can also see that the indentation on that stent equals the narrowest part on that 3D reconstruction. Okay, and this is the final outcome assessed with the 3D array. Okay, so we started 2015 and we use it in different situations in 28 patients initially, and mostly for pulmonary arteries, right ventricular flow tract interventions, and coarctation. And we were able to achieve good, accurate initial alignment in almost 90% of patients. And you can see in every fifth patient, we had to realign that alignment because of stiff delivery system or wires. But overall, we used that successfully in all but one patient. So when to use 3D guidance in the cath lab. So let's say you have technology and you buy into that idea. So, but when do you use it? Do you use it for all cases? It depends who you ask that question to. If you ask that to Gregor Krinks, he'll tell you just use it for everything except maybe ASD or pulmonary or aortic valve dilation. So we looked at our population over 8 years. We had 2,000, almost 500 catheterizations, and we decided to divide them as 3D eligible. So where we would, according to our standard, our knowledge, we use 3D imaging, and exclude, for example, like Rashkin procedure. You don't need, obviously, 3D array for that, for example. So we had 1,660 cases eligible for 3D guidance, and then we used 3D imaging in almost 600 of these cases. So But what I want to point out here that it also depends on the type of intervention. And if you go, if you look here, we used 3D imaging for more than 60% of right ventricle outflow tract interventions. And if you think about it, these are pulmonary valves, and they come with CTs or MRIs, so you have that 3D information available, and if not, you can do 3D array. The same goes for example, coarctation. We also used in single ventricle patients, when we use some collaterals, we can also use that pre-catheter imaging to overlay and to cannulate easily and then deploy devices. But the thing is that when we looked at our 3 operators over that 8-year period, we could clearly see that there is a significant difference in utilization of any 3D guidance between the 3 of us. So there is this operator, how do you call it, operator factor involved in that analysis. But if you look at right ventricular outflow tract interventions, we really like to use it for percutaneous pulmonary valve implantation. This is one of our early cases. This patient had CT done, and here you can see that there is artificial mechanical valve in mitral position. So we use that as an internal marker, and we then also segment the most important part, which is right ventricle outflow. There's a conduit there, and underneath that you can see a coronary artery. When we did that segmentation, I can tell you that we had, and there was a company representative in the same evening. We had a call that, wait a moment, this software is not intended for coronary artery interventions. So that we had that warning not to use it, but despite that, we find it very useful to segment those coronary arteries and to, before the case, to know where they are and to assess the distance between the conduit and the artery. And you can easily do that segmenting before the case, and then during the case you have it on the screen. This just shows that you can use different ways of registering. So whether that is cardiac silhouette or the valve ring that I showed you. And if you look on the screens here, we are delivering CP stand here, which is stiff rigid, but still we have nice alignment of the outflow tract with the 3D reconstruction. You can see that the valve of the mechanical, the ring of the mechanical valve is not aligned to that blue ring, because that overlay is rigid, that's stiff. It's not moving with the heart or with what you create when you introduce stiff equipment. Okay. Then we combined our experience with the German group, with Stefan Schubert from Berlin, and we had they had more MRI data sets. We had more CT data sets for PPVIs guided with the fusion overlay. This is example of MRI derived 3D data set when Stefan placed a valve. And well, first of all, we knew that it was feasible, and in our experience, it enabled us actually to do it in a shorter time. But the comparison of the 2 groups showed that actually when we use CT, we had less contrast exposure, and when we had MRI, we had less radiation exposure with the two techniques. And one of the reasons is that when you have MRI, you don't necessarily have those bony structures, those internal markers to align with. So at that stage, we would inject a small amount of contrast to align it with the 3D reconstruction. But well, if these nice images were not enough for you to buy into that idea, well, the 3D or CT or MRI overlay is not only about nice pictures. And now here I want to go back to those 3D array guided ductal stenting. And if you look, rotational angiography, in that our early experience was responsible only for around 30% of radiation. So we knew that 3D array doesn't give a lot of radiation. There is a lot more you can do between 2 array spins to reduce the radiation. But when we compared 3D guidance to 2D guidance, it was a statistically significant difference in favor of actually 3D guidance. At that time, 2016, the group from Erlangen, which was using that group was using Siemens system, so they published their experience for 3D guided aortic interventions, and you can see here that they were able to reduce radiation and to have shorter fluoroscopy times, and that was statistically significant. A little bit later on, we looked at our PPVIs and we compared to 3 imaging techniques: 2D imaging, 3D array, and CT overlay. And here you have highlighted those that group with CT and MRI overlay. So we had a significant reduction in contrast, also in radiation, and also in total study time. So we were able to show in our experience that there is benefit of using CT and MRI overlay, not only nice images. Then we try to compare our experience, or combine our experience, with the group from Mexico in coarctations. In this group, we were able to show that there was significantly less contrast used when CT or MRI was overlaid, and there was tendency for a lower radiation dose. But more recently, the group from Erlangen showed statistically significant reduction in contrast, radiation, and fluoroscopy time for interventions guided with CT MRI overlay. So let's say now you have bought into the idea, so you need hardware and software for that. Majority of systems now come with a 3D array. Not all systems provide as a CT or MRI overlay, so you have to get that extra. But this is example from GE, and this one is from Siemens. So one of the ways to do CT or MR overlay. And finally, also Canon provides that tool as well. With Philips, we have 2 ways of using CTs and MRIs. One is EchoNav, HardNav, that's the one on the left, and the second one is CT. The second one is Vessel Navigator. So you need to have 3D data sets, whether it's MRI, contrast computed tomography, or 3D array, and then you need to have some knowledge and skills, and there have been meetings dedicated to those techniques, and there are also sessions dedicated to 3D imaging during major conferences. So I think the knowledge is there, and there are many publications. So I'm just going to focus now on just a few examples. What is important that I mentioned already, that segmentation and planning, you do that before the patient comes to the lab. What's important is registration. You need to have some markers. So you can use calcifications, bones, if you have them, previously implanted devices, or you can use airways, for example. When you have nothing and you have MRI data set, you can inject contrast, or you can do something else. But let me just show you, and on this example, I just want to show you that sometimes, not always, the segmentation can be really quick and easy. So this time we segment arterial duct, and it can be done actually with one. Okay, there's 2, second click, and then there's third click, and let me just move here. So we have that. Okay, 3D model. Then I got rid of pulmonary artery branches. We don't need that. And then we go with the coronary wire, and you can see that the wire is contained in that 3D reconstruction. And then we just have stent introduced, self-expandable stent, and those blue rings serve as markers for stent implantation. So not always, but it can be that easy. In this case, I told you that if you don't have markers, you can use contrast injection. But what we have been doing recently, we just place a wire in the arch, and we use that wire, the curvature of that wire, to align it with the 3D reconstruction. So this is an example of that. And then we go for transverse arch stenting, and in this case there was no contrast injection before stent placement, but there are certain actually markers to align that 3D reconstruction, and you can see the catheter also coming from the right arm to the head vessel. So there are many ways of getting a nice overlay. Oh, in some cases you have very nice CT data set, like in this case, hypoplastic left pulmonary artery in tetralogy patient. So you have nice reconstruction with ring markers, and you can then stent that vessel. Okay, sorry, let me go back. So then we just stent that vessel, and okay, this moment here. So you use those ring markers to position the stent. But sometimes the 3D reconstruction is bad because of poor CD or poor 3D data set. So you can use ring markers to help or enhance usability of that data set. You can also mark important structures like native aorta or left main bronchus in this hypoplastic left heart patient. Then here we use CT derived 3D model and bony structures, and we align that. Okay, and here we go with stent implantation. And again, if you look, we have slightly, well, moderately stiff wire, so we do some shift in the anatomy, and we are aware of that, but still we have a nice alignment, at least with the RPA there. And sometimes you just want to stent or dilate a vessel that is not visible on 3D or any type of imaging. So like in this case, when there's a pulmonary vein perforation intended, and what we did here with the group in Colorado, let me just scroll here. So we used 2 points to mark the 2 sites that we want to connect the back wall of the left atrium and pulmonary veins. They're on the right side, and we use that as markers to guide RV pulmonary vein perforation. So you can see here wire going between the 2 markers, and so we can also do that. But with all that experience, we decided to mix and match. So sometimes you can use different imaging modalities. Like in this case, we have a 3D data set at hand. We use that for building the model, but then we still need to test coronaries here. So we do 3D array. And finally, after implantation of the valve, we used intracardiac echo to assess the outcome of that pulmonary valve implantation. This is another case where we decided to use that 3D model for aortic valve dilation. So unlike Gregor wouldn't use that 3D imaging, but I guess it does come with some benefits here. If you look on the right panel, we use again wire in the arch to align that 3D model. And then with no contrast and also with TOE guidance, as you can see on those images, we're crossing that valve, and then there is balloon dilation. 2 balloons used, and no contrast injections, and low frame rate of fluoroscopy. So that all together adds to lower burden to the patient. And whenever it's possible, we can also use ultrasound to assess the outcome of our intervention. And like in this case, we used the CT to build a model of that collateral vessel, and then we used it for guidance to occlude that vessel. But at the end, we used ultrasound to assess the outcome, and again, just fluoroscopy, no angio, no contrast. With all that experience, we looked at our stent implantation with the early years of using CTs and MRIs for overlay, and in selected cases, we were able actually to place the stent without contrast injection. And that's not the aim of the game. It's just when you are confident with that 3D imaging, and you know that even after introduction of stiff wires or sheaths, you have nice alignment. So I think there is some benefit of not exposing the patient to additional contrast or radiation. But this doesn't go for doesn't work for every patient, and you have to be really critical in assessing the alignment of that 3D volume. Most of that experience I've showed you was single center experience, but we wanted to confront that with other centers, and I initiated registry where 5 centers contributed, 1 from Poland, from South Korea, Germany, Mexico, and from US. And we collected over 250 cases in that registry. And if you look here at the average patient, it was around 50 kilograms with CT, came to the cath lab with CT and had coarctation, and the most likely intervention was stenting of the aorta. Most people used just 2 rings to mark the narrowing and the nearby branch. Majority of cases, 2D to 3D registration was used. So just like you do, you setting up isocenter. Most people used bones for registration, and it was at least very useful. Some thought that it was essential, that 3D overlay. But if you just focus for a brief moment on that slide, so again, the major mismatch was initially in less than 5% of cases, but if you introduce stiff toys, that mismatch increases. Still, there are options to modify that and to align the 3D reconstruction along the case. So that is why, if you look here at the usefulness, so you got misleading. There were, I think, 2 cases when 3D imaging was misleading, and in all other cases, operators felt that there was some benefit. Okay, so but you have to understand limitations, and I'm really just going to the final slides. This is a patient, actually neonate, with came to the lab with CT, and we see here collaterals. The CT was taken, I believe it was like 5 weeks, 4 to 5 weeks earlier, and you can see obviously that there is a mismatch. There is a size mismatch between that CT and that fluoroscopy. So you know, it will not work. But the most important limitation is that 3D registration is rigid. So this is just a stiff model, and you align it, and then it stays there. So if you push the patient on the table, you don't have a correct alignment. And if you push some wires or catheters, again, the 3D overlay doesn't track those changes. And if you look here at the A panel, you have 014 wire, which is contained in the vessel. Then when you in the middle panel, you can see we going in with a catheter. It is still in the vessels. But if you look at the C panel, you have stiffer wire, and definitely that distorts anatomy. So in this case, this is useless. Okay. Let me, for the sake of time, skip this one, and let me just. So, you know, if you bought into the idea, if you have hardware, software, you have 3D data set, you have some knowledge and skills, that's good. And if you understand the limitations, it's even better. But if you're not convinced, maybe Evan Zahn, the person who actually inspired me to use 3D imaging, and it was in PICS 2010 in Boston when he showed his nice presentations of 3D array utilization. So you cannot probably hear his words, but what he is saying, using CT and MRI in a cath lab is genius. We should do more of it. Okay. Thank you very much to many people who have worked with 3D imaging as a team sport. I also thank to those who don't believe in it and challenged me along the way. That is always beneficial to discuss cases and to be critical. And thank you, Riz, again for that Denver experience and for that kind of invitation.
Thank you, Sebastian. That was a fantastic talk. I think Marinos has some questions for you.
Yes, I have 2 questions from the panel. The first one is, how much time is the procedure does the 3D construction add?
For 3-dimensional rotational angiography, you can have, it kind of depends on anatomy and amount of contrast you inject and how good your 2D images are. If they're really good, you can have instantaneously, you can have 3D reconstruction for like coarctation. But if you have more complex structures like pulmonary arteries and you have some branches and you don't want them on the overlay, you have to cut them out. It can take several minutes. You have to be, you have to focus. You have to be critical. I just need, you know, that part of that vasculature, and then the simplest way is actually to encircle and do the cut out what is outside. So then it doesn't take much time. And for CT or MRI fusion, you do it before you bring the patient to the lab, which is actually tempting to overdo, to spend more time on segmenting this and that and putting those rings, and it takes more time and it gets you home later than you would want to be.
And the second question that we have from the participants is, do you need the protocolize to do the required for the CT MRI, a special protocol more or less to do the CT in order to do then the overlay? Or you just run a CT and an MRI, and then you use the images that you have with a 3D reconstruction and you do the overlay?
Oh, well, that's a great question. All the images I've showed you, there were just random scans. I mean, not intentionally modified scans. This is what patient come to the lab with. This is what our colleagues send the patient to us with. We try to segment. We try to put some rings or points to compensate for some limitations of the 3D data sets, but we haven't established special protocol for fusion of 3D data sets.
Thank you very much.
Thanks, Sebastian, for the talk.
Thank you.